So would it be fair to say that this acuity adjustment is really also baking into what would have shown up in the risk share, which is still 0?
That's correct.
And is any of it based on the experience? I know there's a lag time here, but on the risk share, so would we have seen a risk, you've got whatever we are, more than half the year is over, 3/4 of the year is over. Do you have that data?
Yeah, so based on experience through December, which is still preliminary reporting because it includes a fair amount of lag, the plans are pretty close to break even. Some of them are reporting slight gains, some of them slight losses, but on net wasn't significant enough for us to include an estimated risk share payment because we don't anticipate needing one, which seems to reinforce that this acuity adjustment that the actuaries applied was necessary and aligns with what we're seeing, at least in preliminary reporting year to date.
And how much data is that? I don't think I heard you say how much you had.
So it's through December, but there's only been 2 or 3 months of lag since claims that since the December month. So there hasn't been much lag. So their estimates include a significant factor for the incurred but not reported experience that could potentially swing fairly large amounts in either direction, which we've seen with the plans during the COVID period, for example, where a few of them thought they would be experiencing significantly worse outcomes than where they finally ended up.
So just to confirm, when you say it's through December, you're saying it's what they've reported through December, but it's missing information that would have been incurred in December? Is that what you're also saying?
Yeah, so it's for dates of service, July through December, but there's only been now 2 or 3 months of run out from December claims. So their estimates that they report to us include a significant incurred but not reported allocation at this point in time. And that allocation will decline as the months go on throughout the fiscal year. So their reported value will get closer and closer to the actual experience. But that process takes a very long time. So we had a 12-month run out on the risk share arrangements, and those estimates change essentially every month throughout that 12-month run out period. So it is very early, but it's encouraging that at least the reporting year to date with those estimates for IBNR are close, really close to the certified rates.
Okay, thank you.
Okay. Moving to 22. So the increase for fiscal 22 is $56.8 million over our current year estimate. As I mentioned, this is a $53.3 million deficit against the November adopted. The changes for the drivers for the increase are a 3.5% assumption for price going into fiscal 22. That could change based upon the final certified rates. You'll see if you look forward at table 3.4, the price volume comparison, the price factor is higher at 3.9% for fiscal 22 over fiscal 21. The difference between that and the 3.5% price factor that we're assuming for capitation rates is a change in the enrollment mix of our population. A disproportionate amount of the increase that we've been seeing since February is amongst older right care individuals. We've always had pretty high penetration rate amongst children who are eligible for Medicaid. What we're seeing now is more parents under 133 or up to pregnant mothers up to 50 who are eligible for Medicaid coming on, and so they usually have they do have a higher PNPM, and so as their share of the total population increases, the composite rate is increasing as a result of that. Also, the gain share that we're assuming in fiscal 21, the $4.6 million gain share for Right Smiles, we're not assuming that in fiscal 22, and so that does lead to a higher price factor change. And then we're also assuming a higher enrollment in fiscal 22 relative to November as a result of the continued moratorium on terminations. Our right share numbers continue to decline slightly or stay relatively flat. Overall, we're still seeing savings per member there, but it's just there's a low take up now, largely as a result of probably COVID and lack of employment opportunities for those individuals. What follows then is a series of tables with all the supplementary data that the conferees can use to interrogate and or amend our forecasts. If you have any questions, happy to take those now.
I think we're good.
The final thing for managed care is the CHIP and family planning claiming. This is just an adjustment for the GR federal funds splits. CHIP claiming remains steady. We're seeing an increase over the enacted and the adopted, largely due to the increased enrollment that we're seeing. Moving on to Rhode Health Partners. For Rhode Health Partners, our budget is for the current year is $288.8 million. This reflects a $3.2 million deficit over the enacted. For fiscal 22, we anticipate an increase to $296.5 million for a $2.2 million deficit over the November adopted. In both years, we have a GR surplus, again, attributed to the COVID relief. For the current year, there's not much of a change. It's largely flat relative to enacted, just a change of 48 average member months over the enacted in fiscal 22. And for fiscal 22, a slight increase of 100 member months relative to the enacted, and that's due primarily to keeping the enrollment flat going forward. We would otherwise experience a slight negative reduction. Some of the highlights for the current year, we are seeing a reduction in rebate collections, as Chaz discussed earlier. That's in the current year, getting smoothed out over the 2 fiscal years as we are improving our treatment of the prior period invoicing. And hepatitis C expenses are down slightly due to a reduced utilization within this product line. As Chaz mentioned, the health insurer fee was up slightly relative to what we had assumed in November. Just one minor correction to what Chaz had said before. The tax that we had underestimated was not just the premium tax. It's the HIF, the health insurer fee, is after federal income taxes, and so it didn't affect Tufts, which has a pseudo nonprofit treatment for purposes of the health insurer fee, but for United, their marginal tax rate was applied to health insurer fee, consistent with CMS guidance. Any questions for Rhode Health Partners for the current year?
Looks like you're good. Keep going.
Okay, for fiscal 22, again, not much there. Enrollment's relatively flat, and we're applying the 3.5% price increase. Details in all of the forecasts and enrollments are provided there. For Rhode Health options, we are seeing a surplus with our current forecast of $128 million. This is a surplus of $4.6 million over the enacted. That surplus carries forward into fiscal 22, where we're forecasting $144.8 million for a surplus of $6.9 million. The two main drivers for the surplus are a slight reduction in the number of enrollees year to date in the demonstration compared to what we are assuming, what we had assumed in November and what was reflected in the enacted. The larger change is due to a reduction in the composite rate for the demonstration. Neighborhood, who provides services for the Rhode Health Options Phase 2, or the CMS demonstration is also referred to, they get a bundled payment for their LTSS members that's derived from the relative mix of members who are in the nursing home and members who are in the community getting LTSS services. That ratio has changed significantly, so they're enrolling a disproportionate number of people in the community compared to in the nursing home. The key people in the community have a much lower PMPM than in the nursing home, and so we're seeing a reduction in that blended rate. We're also not forecasting any risk share or gain share for that. They're currently in year 4 of the demonstration, and last year they reported slight gains for the program, and no risk share was paid to them. And for demonstration year 4 and onward, there's no more risk and or gain share stipulations for that program. So we won't be budgeting any kind of risk mitigation for that program going forward. We are, however, including in our estimate, and this is what's driving up the increase in enrollment in fiscal 22 over fiscal 21. We're maintaining the assumption that 150 new members will be passively enrolled into the program each month. So the underlying trend for Rhode Health Option is flat relative to our March enrollment, but we're adding in 150 new members each month for passive enrollment. You'll see some reductions in the fee-for-service estimates as a result of that, because more and more people will be shifting from remaining in fee-for-service to Rhode Health Options. That'll particularly impact fiscal 22. As Chaz mentioned, both years for fiscal 21 and fiscal 22, the rates assume the reduction for the opioid treatment program that are now covered by Medicare, and so they're being paid for by neighborhood still, but they're included in the CMS component of the rate as opposed to the Medicaid component of the rate. And that $1.1 million savings for the opioid treatment is reflected in the certified rates being paid. And so if you look at table 5-1, you won't see the OTP SUD savings is blank. It's because it's built into the capitated rates that weren't finalized back in November. Any questions on Rhode Health Options?
Oh, you're good, keep going.
Moving on to Medicaid expansion, where we are seeing significant changes from both the enacted and the adopted. For the current year, our revised forecast of $665.9 million reflects a $25.1 million deficit over the enacted. For fiscal 22, our estimate of $767.4 million reflects a $125 million deficit over the November adopted. Unlike in the prior three budget lines, these do contribute to a GR, general revenue deficit, both in the enacted and in the subsequent fiscal year, because they're not eligible for the enhanced match. For the current year, the primary drivers for that increase is, as we've discussed at length, the acuity adjustment, $30.4 million in additional payments to the health plans is attributed to a change in the rates between November and now. Overall, we are seeing a 4.4% increase in the composite rate between the November forecast and today. Lower than anticipated rebate collections are also adversely impacting the current year. Some of the savings that we are seeing is a reduction in our fee-for-service expenses. The number of people remaining in Medicaid expansion fee-for-service continues to decline as we're seeing less churn. So presently, the 3,600 people in remaining in fee-for-service on average is significantly less than that we were seeing in fiscal 20 or prior. Overall, over 96% of our members in Medicaid expansion are enrolled in managed care. This is significantly more than around the 92, 93% that we were seeing prior to the pandemic and the moratorium on terminations. We do expect that our fee-for-service expenses will increase in the subsequent year as terminations happen and people probably come in and out of eligibility status and get put into the pre-enrollment period. And so you'll see that our fee-for-service expenses going into fiscal 22 are higher than the current fiscal year, despite the overall reduction in members remaining in fee-for-service. Sorry. For fiscal 22, the main drivers are increased enrollment and a continuation of the application of the 3.5% rate increase for the capitation rates. Two things to mention that are new for fiscal 21. One is new for this estimate, and the other one we addressed back in November. There's a group of members who are previously eligible, who were previously eligible for Medicaid per the regulations in place prior to January 1st, 2014. These are generally people whose income is below 133% of poverty. They don't have children, yet they're eligible for SSI or RSDI. These people are able to go through the MAGI pathway for purposes of eligibility determination, but they're not eligible for the enhanced 90% funding. Our system doesn't correctly identify them from a MMIS perspective, and so we have to do a prior period adjustment for this group, and so we're estimating based upon what we saw that we accrued for, and then we did the adjustment for CMS purposes for last year. We're assuming that's carried forward into the current year and increasing it due to the increased enrollment. So that of the 665.9 million in the current year, 12.5 million is not eligible for the 90/10 match. It is eligible for, though, the enhanced regular FMAP rate. And so our splits do recognize that. The other adjustment that we are making is for Right Smiles. As people age into Right Smiles, now you can be up to 20 and be in a Right Smile. So those 19 and 20-year-olds who are eligible under Medicaid Expansion, they will remain in Right Smiles. They're no longer getting disenrolled, but we're eligible for 90/10 match for that. So we are shifting 1 million in fiscal 21 and 2 million in fiscal 22 from the managed care Right Smiles estimate to the Medicaid Expansion estimate. Any questions there?
I think you're good.
May I pass it on to you?
Yes, thank you, Grant. Good morning, conferees. I'll be leading you through most of the fee-for-service estimates, which begin on page 39 of our testimony. The first section is our hospital inpatient outpatient estimate, which does include the UPL payments and the GME. For fiscal year 21, we're reflecting a $2 million surplus compared to the enacted. This is largely due to activity that we're seeing in inpatient hospitals, claims activities. As you know, we use the claims data and estimated payment and completion factors to determine our spending. And so this surplus just reflects the updated data that we've had since November. In November, we would be forecasting what we anticipated for October, November, December, January, and the remainder of the year. So now this just reflects updated estimate to that number based on activity. Also in fiscal year 22, we are seeing a deficit that's again driven by largely the inpatient hospital activity and higher anticipated UPL payments, which I'll talk about in more detail in the next few minutes. But I did want to orientate you to our state fiscal year 22 estimates for the bulk of fee-for-service. We've chosen to present a conservative estimate based on the continued uncertainty, vaccination rollout, and COVID activity. So what we've done for our fee-for-service estimates is take for each line item the higher of 2 periods. So it would either be the current trends that we're seeing, which is July 2020 through December 2020 activity, or the pre-COVID period, which was July 19 through March 20. So if you'll look on the bottom of page 39, you'll see table 7-2, and you'll see this throughout our fee-for-service testimony, so you know which estimate we used. And so because we're projecting inpatient activity to sort of as a conservative estimate trend of what we're seeing now, that does drive the deficit compared to our November, which is anticipated to be 3.5 million. Going on to page 40, you'll see our market basket assumptions. I should note that in state fiscal year 2022, we're anticipating a 2.4% market basket adjustment to both inpatient and outpatient, and we do have more detail on those hospital market baskets. And I'd like to speak on that for just a few moments. Sharon, to address your question that you asked Director Schaefer at the beginning of the testimony about why wasn't it included in the GovRec, and why do we have all the clarifying language? I think the response would be that traditionally the governor's recommendation doesn't usually handle the market basket language. We go with what's in current law, but also many times the General Assembly doesn't enact the actual market basket. So when we actually go to make the adjustments for the market basket, it's been quite a number of years, I think, since we've had to do that. And current law does say this, the statutory, the scale that we have to use, the CMS inpatient, outpatient. But when you actually enact it to the market basket, depending on when you prep the rate changes, they may change because the forecasts are updated quarterly, but the actual market regulation market baskets are updated annually. And so there's this chance that if the General Assembly does not make a change to current law, that what you approve in the caseload testimony and in the enacted budget as an estimate based on a market basket increase could change. And so we're making these suggested, or we'd like to make these suggested changes to our state plan to not only clarify what we should use when we implement a market basket, but to ensure that what is enacted based on our testimony won't change when we actually prep the rate changes. So it's really for clarity going forward, so everyone's aware of what we're using, and to ensure that we're not enacting something that wasn't adopted in the enacted budget. And so I'm happy to walk through some of the technical language if you'd like, or answer any follow-up questions you do have on the market baskets for the hospitals.
In this particular instance, as I read it, you're only suggesting clarifying what it is you submit to the feds. Am I correct?
Yes, because in the current law, it's sufficiently broad. It does state which inflationary index to use, but when you actually go to the CMS website, you have the choice between an actual market basket regulation, a productivity adjustment, or a forecast. So we just want to clarify in our state plan the very specific nature of what we're going to do to the rates.
Right, and so this is what you've been doing, you're just
documenting the
your
current, yes,
document.
correct.
Yeah, okay, thanks.
And the only thing that's a little strange about this is the inpatient hospital actual market basket regulation goes by the federal fiscal year, and the outpatient goes by a calendar year. So if you actually look at our proposed language, you'll see that's the cause for the slight difference in the language.
Thank you.
Moving on to page 41, this is our upper payment limit estimates. For fiscal year 21, the enacted budget included $7.9 million, and as of our testimony and according to law, we've paid the final fourth quarter payment to all the hospitals, so we have made no change to that estimate. I should note that in state fiscal year 22, we are using the $7.9 million amount as a placeholder, which is the enacted budget. And there's a very specific reason for this that we go into a lot of detail on. Essentially, because of the public health emergency, CMS extended the due dates for the Medicare cost reports. And we do use the Medicare cost reports to determine the UPL gap. And so most of the hospitals are on a federal fiscal year, but there are a few hospitals who are on a calendar year. So those hospitals who are on a calendar year have until July 31st to submit their Medicare hospital cost reports. And what's difficult about this for us is that when we submit our demonstration to CMS for state fiscal year 22, that's not due until June 2022. And so we have to use the most recent hospital Medicare information. And so for us, we would have to wait to calculate the UPL and submit that to CMS. We didn't do that for you now because we don't have those cost reports. However, I know that according to law, the state fiscal year 22 UPL payments need to happen quarterly beginning in July. So what we can do is we could get an estimate to you after the fact if this is something that the conferees are interested in, where we take the most recent cost reports for the hospitals that we have, and then we use as a placeholder old data from calendar year 2019 for the hospitals for which we're lacking cost reports. So we wanted to make you aware of that, and we're happy to send that to you if that's something you would like. But we should let you know that if you do enact a UPL amount, when we submit our demonstration to CMS, the amounts will vary. Did you have any questions on that?
I think we're good.
Okay. So we'll move on to the graduate medical education section, which is on page 42. We had some clarifying questions for the conferees that we've summarized in the middle of page 42. Just like to go over. Generally, the state law allows for a total GME pool of $4 million. The state plan has that set at $1 million. We've requested from CMS that if we could create a state plan amendment to match that total maximum pool, and they have not been fairly receptive to that idea. They'd like us to update the total pool amount annually, which necessitates a state plan amendment. The FY21 enacted budget assumes that we increase the pool from 1 million to a higher amount. However, there wasn't Medicaid resolution language in the budget authorizing us to make that state plan amendment. And so we just seek clarification from the General Assembly and the conferees as to whether we have that authority. We interpreted it since as the additional money was included in the GME, for the GME payment in the enacted budget, that we did have that authority. So we did post for public comment a possible state plan amendment to increase the total pool with what we thought the intent of the legislature was. And so if you're in agreement with that, our total GME payment will be 2.5 million. However, if we misinterpreted this, we would have to keep the total pool at 1 million, which would reduce the GME payment. Would be an all funds payment of 1.6 million, which we detail on the bottom of page 42. Luckily, fiscal year 22 is a bit more clear. We'll hopefully have a Medicaid resolution, and we would again increase the total pool from 1 million to 2.2 million and receive a federal match on that prevailing FMAP. Any questions on that?
I don't have any questions. I would say that we all assumed that the 1 million general revenues would be matched by the appropriate amount of federal funds. I'm trying to remember, have there been years where we've had a GME resolution language? I know that typically there's a request to get rid of it, but when we restore it, I don't recall that we put it in the resolution. So
Fiscal year 20 was the first year that we were able to get match. Previously, the UPL, prior to the elimination of the UPL payment, there was not the ability to get match on the GME payment, so this is a new issue. But in fiscal year 20, we did have the ability in the resolution to seek the match.
Okay, so I'll have to look at that, but my understanding is that the appropriation of general revenues signals the match, and the law has you able to do this up to 4 million. So I think you're good if you adjust it to cover. I think that makes sense.
Perfect. Yeah, we've posted the for public comment. We just wanted to hold off actually formally submitting until we clarified that. So thank you.
I do have a question about, and maybe you're going to get to this and I'm jumping ahead, but the recouping previous payments discussion. Should the governor's recommended hospital license fee increase pass, EOHHS will need to recoup previous 2021 payments?
Yeah, so if there's the hospital license fee is actually factored into the UPL model that we submit to CMS. So if it's a higher hospital tax that they're paying, it reduces the UPL payments available to the hospitals. I think when we originally did the estimate, it wasn't, I want to say it was less than 100,000. That's something we could forward to you so you could see the impact per hospital. But because it is a change and it does impact our demonstration, which we submit to CMS, and we've already paid by law the quarterly payments, we would have to make some adjustments to those payments.
Okay, yes, if you could just forward the what you think it looks
Yeah, we
like,
can.
that'd be great, thanks.
Yeah, absolutely. Moving on to page 44, which is the DISH discussion, which we briefly touched on at the beginning of our testimony. So for state fiscal year 21, the enacted DISH payment was $142.3 million, and we've left that as such in our current estimate, so that is no change. Chaz did mention an increase, a significant increase in our state fiscal year 22 estimate, and that is primarily it's only due to the Consolidated Appropriations Act, which deferred the DISH reductions. So as a result of that DISH reduction, we have budgeted the DISH payment based on our preliminary allotment that CMS provided to us in October 2020. As in the past, this is subject to change, and we are anticipating that we might receive further guidance based on the American Rescue Plan. But I think it's important to note from the purposes of CMS's perspective that they have clarified that the DISH payments are eligible for the enhanced 6.2% FMAP during the PHE, and that they have stated that our allotments wouldn't change. And so because of that, it effectively makes it less costly for the states to access their full federal allotments, but it reduces the all funds amount paid to the hospitals. So I'd like to point your attention to the table on page 44, just to show you that how CMS accounts for our DISH payments. They do count, they view us as making a state-only payment, because in their mind that they're deriving our total DISH payment based on our utilization of the 6.2%, and anything above that is considered a state-only payment, and that becomes a little more clear when we look at what happens in light of the American Rescue Act. So we tried to summarize this on page 46. We have a table there, table 8-4, which shows how we account for the DISH payments when we report to CMS, and you can see that there's that lower all funds number. So for example, in state fiscal year 2021, the one we've recently made, from CMS's perspective, we made a DISH payment of $127.8 million, because we would have been maximizing or getting our total allotment from the 60.29% and our unchanged federal allotment. But in RIFANS, when we pay it, it's actually a little quite different. We reflect the unenhanced FMAP DISH payment. And so you can see that from CMS's perspective, they're thinking that we made a $13.8 million state-only payment. This becomes more important as we look at the American Rescue Plan of 21, which passed recently, and stated that the Secretary shall recalculate the annual DISH allotment. There's a lot of uncertainty regarding what this means. We have not received any communication from CMS stating that our federal allotment has been increased. We are relying on guidance that they say is forthcoming, and we've also checked with our counterparts in other states to determine, their interpretation of this. We have some scenarios that we've put together to show you what a favorable interpretation of this could look like if they do increase our federal allotment for the share. And so those are on the tables are on page 47. So we can start with, I think, state fiscal year 22, which is table 8-5. So scenario B is sort of what we've anticipated current law is and what we would pay. So you see our unchanged federal funds payment of $77.1 million. And from CMS perspective, we're making that at the enhanced FMAP, so which it reduces our state share. But to keep the hospitals whole, traditionally what we've done is we made this additional state payment, which equals the $142.5 million in our testimony. A favorable interpretation of the American Rescue Plan would be that CMS increases our federal allotment, which is a scenario C. So you can see that the 77.7 that we have budgeted might go up to 85.9. It reduces our GR payment, and we don't have to make the additional GR payment. So it's a net savings of $8.8 million. That's just an example to illustrate what could be a favorable interpretation and what savings you might be looking at if it's interpreted that way. But again, there's still a lot of uncertainty around this specific provision. I would also note that we are uncertain if it would be retroactive to our state fiscal year 21 DISH summary or DISH payment. So we have a table also on page 47, table 8-6, which details what could happen if it is a favorable interpretation and they do make it retroactive. So the savings would basically be the variance between scenario D, which is again increasing our federal allotment, compared to what we actually paid, which is in scenario A. I hope I did a good job explaining that. That's a little complicated, so if I didn't, please ask me clarifying questions.
So just in summary, we're going to leave everything as it is until the feds tell us we can claim more? And,
Yes.
And they could tell us we could claim 0, they could tell us we could claim 8.8, or possibly the full 18, almost 18 million, right?
Yes, that's exactly what we did in our testimony, but we wanted to just give you an estimate of what we could be looking at.
Yep, that's helpful, thank you. Joe, are you good? Okay, keep going, thank you.
All right, so moving on to page 48, you'll see our nursing and hospice care estimate. So we are projecting a surplus in state fiscal year 21 of $32.7 million above the enacted. And again, that is due to updated claims activity showing reduced utilization. In state fiscal year 22, for these line items, we are also projecting a surplus. The surplus over the November CEC is looking to be $13.8 million all funds. There are two reasons for the state fiscal year 22 surplus. Number one is, again, we're using a conservative estimate using the higher trend seen in two different time periods, and we've selected the pre-COVID time period for that line item, specifically nursing homes. Hospice is a little different. Also, we're seeing a reduced market basket. In November, we projected a 2.5% increase, which was a cost of 3% to the state. But based on the actual market basket regulation, we're looking at a 2.65% increase, that's the cost to the state, and a 2.2% increase paid to the actual nursing facilities. So it's that combination of a reduced inflationary adjustment as well as the time periods we're using for the estimates, which lead to the surplus in state fiscal year 22. I should note that throughout the testimony here, we're trying to illustrate the Medicaid census being down, especially in the most recent months, but we are seeing evidence that that's increasing, that may increase, and our latest MDS data is showing sort of the ratio of admits per discharge. We see that creeping back up in our latest monthly one, which leads us to think that yes, there is increased activity, and we are projecting that to increase as COVID eases. We've also tried to do a better job with the conferees to illustrate the effects of patient share in our rates, and also how that affects the estimate. So our typical table that you're used to seeing, which is the effective rate date, the average nursing facility per diem, and we've added another column to show you the effect of that per diem, less the patient share. In our state fiscal year 21 and 22 estimates, we assume a 17% patient share. I should note that prior to presenting our estimates, we do check this in our claims data to see if that varies at all, and it's remained between 16 and 17% for the last few months. So we don't have any evidence that there's a significant spike or a decrease, but if there is, that's something that we would adjust. And the remaining a few tables in the nursing facility section in hospice, they're really situated around the market basket increase, what we used in November, how this testimony differs for state fiscal year 22, and again, clarifying language that we'd like to submit in our state plan to make it very transparent of how we apply the rate adjustments. And those can all be found on pages 50 and 51. I'm happy to answer any questions you might have on that. Any questions?
I think we're good. I guess I want to just, again, clarify in the patient piece. Everything that's here, as I read it before, basically you're saying that because patients don't really have what they owe is usually a fixed dollar amount or doesn't grow with other things, the cost to the state for every market basket increases because the patient share effectively doesn't. Is that accurate?
That's accurate.
Okay. Okay, I think keep going. We're good. Thanks.
Oh. All right. Moving on to home and community-based services. That begins on page 53. So we are anticipating a 5.6 million deficit compared to the enacted, and this is again due to the current trends that we're seeing in our decision to go with an estimates that either the higher of the pre-COVID or the current trends. We are seeing, due to COVID, increased home and community-based services utilization in all areas except from adult day and other home and community-based services. So where we have deviated from our methodology for adult day, we've noted. So essentially adult day is very low. Normally we expect it to be spending over $300,000 a month, but it's lately been below $100,000 in the current trend. So we do think that that's an impact due to COVID. In state fiscal year 22, we are projecting home and community-based services to have a deficit, all funds, of $6.7 million. Again, this is due to the trend that we used. Back in November, we assumed a return to pre-COVID levels, but we are seeing increased utilization that we think, yes, it's attributable to COVID, but it's also attributable to some of the systematic changes that we've been making through some of our programs and building up that capacity and supporting our providers. So we have decided to maintain the current trend through state fiscal year 22. We detail the reasons for that selection on beginning on the bottom half of page 54 and on page 55. We are seeing that the workforce has been particularly strained, but as COVID subsides and the workforce returns more to normal, we could see the capacity expanding and more people taking advantage of that, to which they already have begun doing what we're seeing in the recent data. The other thing to note is the market basket increase that Director Schaefer mentioned, and we have a significant discussion on that on page 56. The current state law states that we have to use the New England Consumer Price Index for medical care. And in our state plan, it's not consistent on which data release we have to use. For our non-hospice rates, we don't have a month, but for our hospice rates, it says that we have to use the May data. Now what we're requesting would be a state plan change because we want to actually move it from the May data as a basis for the change to the February data so that what we present to you and that you enact or the legislature would enact if we stick with the market baskets, that's the actual change that we would put into the system come June when we actually prepare the rates. Because if it's not February, you could adopt an inflationary increase that we're presenting now, but according to our state plan for hospice, we have to go with the May release. So what we like to do is put that clarifying language to, number one, standardize the data release that we use in each month between the non-hospice and hospice rates. And second, to make sure that what you adopt, it is in the enacted budget, doesn't change when we prep the rates. This one's a little different because it is a different scale. It's not the CMS scale. So we have an extended discussion of that. And as Director Schaefer said, the February release is noting a 0% increase. And as of now, the state law says we have to give an inflationary increase, and it's like negative. So we built in all the estimates as 0% for state fiscal year 22.
Linda.
Des, for the information that's on page 53 for the claims data by assisted living facilities, shared living, and adult day, could you give us the monthly breakdown for the year similar to what's in attachment C of your testimony? Because it doesn't include the adult day or the shared living, so it's hard to get through an estimate based on the backup that you guys have provided.
So I'm clear. You want the backup for assisted living, shared living, or everything on that chart, or just
everything on that chart, please, so that we can separate
by
it.
month?
Yes.
Okay, perfect. We can get that to you.
And there's a $2.2 million increase in assisted living, which, based on the testimony, part of it has to do with changes made in March.
Yes,
thank you
for bringing that up. Yeah, so we actually submitted an emergency regulation which was approved, which was to increase the personal needs allowance to $120 for all recipients, and also to maximize the room and board allowance. And so they'll change depending on your group. Let me just pull my notes so I give you the correct amount, and I can explain that. So we're proposing that for the non-SSSP residents, that it goes up, the room and board allowance goes up to $1,471 for a single room or $1,250 for a double. And then the current category F, there's really no change because they're at a max. And the current category D people will have an increase. So when you increase the personal needs allowance and you increase the room and board allowance, it leaves less money available for the beneficiary to contribute to the cost of care. And so we made a below-the-line adjustment in the amount of about $350,000 in the current year, assuming that patient share is kind of eliminated and Medicaid has to, pick up the difference of $350,000. And then in state fiscal year 22, it's $1 million. And so if you want more detail on that, I could send the conferees the model. But that was a technical change, and we did that in order to comply with a federal regulation, which mandated that we couldn't have different maximum maintenance of needs amounts for assisted living. And if you looked at our current system, some people were able to keep $100 for the personal needs allowance, some could keep $120, and so it wasn't standard. And so CMS said we really had to change that.
Can you speak to how that relates to the proposal in the governor's budget regarding all of those items, actually? This looks like sounds and looks like one of those.
Yeah, Yeah, so the governor's budget, what it proposes to do is eliminate the category F payment and reinvest that money that we would be paying as a general revenue only funding payment to these individuals and putting it in increased Medicaid rates because we're going to have a new tiered system. And so they all are tied together, but essentially what the proposal seeks to do is create equity among the recipients, reduce the administration of the current system because it's a bit, cumbersome and it's difficult to understand, streamline it while keeping the beneficiaries and the assisted living residences whole. The purpose of the LTSS initiative is really to repurpose that money and to get a federal match. And to give and to account for patient acuity, because in our current system, for assisted living, you get $69 a day. We're not on par with other states who acknowledge patient acuity. Our payments are rather low, so it's a whole system redesign, and the elimination of the SSPF is critical to that because we can repurpose that money and get a federal match. I don't know if I answered your question or not.
Just, is there not a proposal to increase the amount of that folks can keep, not unlike what you have here as a technical adjustment regarding assisted living?
Yeah, and if you want, we have prepared examples for each type of person, whether they're SSP, D, or F. Currently, and as an individual and an assisted living residence, how those changes would impact that individual. And if that's something useful, it's kind of a large workbook. If it's useful to you, Sharon, we can certainly send that to the conferees because I think it helps when you look at individual examples of a person and an assisted living residence and how that change would impact them.
I guess I'm more getting at why is one thing going through just a technical adjustment to caseload and one thing is going through a formal process where you budget the money, make the policy change.
Yeah, I think, and I don't know if anyone on my team wants to speak to this, but my understanding based on the meetings that I've been in, the conversations that we've had, is that if it's a technical change that needs to be made and it's an emergency reg, that there's sort of a different process for that, but I might allow anyone on my team who could add to that.
Well, maybe before you do, this regulation about, you're saying this regulation only became effective in March? This isn't something we knew about?
No. The federal regulation has always been effective. We were just not adhering to the federal regulation as well as we could have. And so the change to the Rhode Island Code of Regulations to allow us to better comply with that federal regulation, it was approved in February, but the actual change to the dollar amounts that you're seeing was being operationalized in March.
So if I can, this is Ben, and then I'll kick it back to Des or Katie. I think we're talking about two things here, Sharon, if I understand your question correctly. One is, why did we make the personal needs adjustment in regulation sort of outside or before the caseload process or before outside the governor's budget process? And then how does that personal needs adjustment relate to the governor's budget recommendation on changing the home and community-based services maintenance of needs allowance? Let me pause there. Is that what you're getting at?
I mean, they're probably not entirely related. I guess I'm thinking about process. Like you knew about this regulation, yeah. You knew you were changing it. I didn't see it in the governor's budget even accounted for dollar amount wise. So this thing's been in play for a few months and this is effective March 1. Why is it just showing up now? Where the other thing you are planning to do, it does appear that you think you need permission and you need to budget the money. This just seems to have gone through a different door and outside the budget.
Yeah, so the basics of that, and Katie or Des add on, is a policy change versus a compliance change. The personal needs being a compliance change and therefore something we had to do to get into compliance, and then the policy change for the maintenance of need allowance being separate.
But it was known about before the budget was submitted, right?
it was known about, I have to go back and say, exactly when we knew about it. It was roughly around the same time, yes.
Okay, thanks. Any other questions? You can keep going, thank you.
I'm actually going to switch it back to Grant to take you through the remainder of our testimony, beginning with pharmacy. So Grant, it's all yours.
Thanks, guys. Beginning with pharmacy, which is our limits budget line, we are currently forecasting $100,000, a negative $100,000, negative $100,000 from the pharmacy line, which is a $700,000 deficit over the enacted. For fiscal 22, we are forecasting $100,000, which is nearly $1 million deficit relative to fiscal 22. As we've discussed in previous years, the reason this budget line is fairly slim is the treatment of drug rebates and J-codes on the fee-for-service line. Most of our non-Medicare line are enrolled in managed care, and so most of the rebates that we see are managed care drug rebates. However, in the fee-for-service line, all of the J-code rebates, which are the rebates that we get for services rendered in the hospital for our fee-for-service population, are budgeted against the pharmacy line, which leads to nearly equivalent amount of rebates relative to our pharmaceutical spend within the pharmacy. So there's just an imbalance between the expenditures and the rebates within the pharmacy line. The estimates here do reflect the proper allocation of the expansion in the managed care fee-for-service rebates to their appropriate budget lines, and we had made that adjustment last year for with respect to our accruals and final settlement for the pharmacy rebates and fee-for-service. The pharmacy clawback, that is the Medicare Part D premium payment program. We are forecasting a $7.6 million surplus for fiscal 21 for total spend of $58.1 million in the current year. And next year we are forecasting $69.1 million with a $6.6 million surplus relative to November enacted. This is a state-only account. We do get subsidies for it, but we just pay the federal government for the state share. So we do get, in both years, the surplus is attributed in part to the enhanced FMAP as it relates to COVID. We are seeing a reduction in the multiplier. So unlike the other accounts, if you're looking in RIFANs, there's no COVID-related enhancement fund for pharmacy. We just see that in a reduced state expenditures in both fiscal 21 and for the first half of fiscal 22. Additionally, in the current year, the $7.6 million surplus, approximately $5 million of that is attributed to a prior period adjustment. This dates back several years where CMS incorrectly assigned a payment for Part D to Medicare Part A account, or Part B account, sorry. And that has been cleared up in the current fiscal year. So we are seeing that $5.4 million credit to the pharmacy clawback account. Overall, enrollment is fairly close to our target. We are up slightly in the current year and down slightly in fiscal 22 relative to what we had assumed previously. For these estimates, we are reliant upon invoices from CMS for and this is same for Part A and Part B that we'll be speaking to in the next section. We get invoices every month. We have invoices through March for Part D and through April at this point, or May, sorry, through to date for Part A and Part B. So we take those estimates and are just trending those forward, not applying the same logic that we do for the rest of our estimates, where we were looking at the pre-COVID trend and trending that forward, or the post-COVID trend and taking that forward. I'm just looking at the year-to-date trend that we've been seeing. It's not moving at the same rate, because it also does include the Medicare premium payment only program. So this is your SLIMB, QIMB, and your QI beneficiaries, and they have exhibited fairly stable growth patterns, and so it didn't seem appropriate to assume any significant reduction post-COVID, or post the public health emergency in January. Any questions on the clawback?
No, you're good.
For other medical services, we are forecasting revised expenditures of $134.3 million for a $4.2 million surplus over the enacted in fiscal 22. We are forecasting an increase to $143.4 million for a $3.4 million deficit relative to the November adoption. In both years, we have a GR surplus. Just to go over the major variances for that, those changes. The fiscal 22 estimate, the sum of the surplus is attributed to the treatment of the non-emergency transportation rate increase that was budgeted in the enacted. All of that increase, I think it was in total was $2.6 million. It was either allocated to other services, transportation line, or Medicaid expansion. In reality, it was distributed across all the budget lines, Rhode Island Health Partners, managed care. And so the $2 million surplus that we're seeing in non-emergency transportation within other services does not represent the surplus on that total contract. It's just relative to this budget line. The other major variances are our rehab and targeted case management is down relative to the enacted, as are physician services. Physician services is likely attributed, the reduction in there is attributed to lower utilization of those services during the pandemic. And the other change is all other services, which is sort of a catch-all of things that don't fall nicely within the other categories, is showing an increase of $1.4 million. As mentioned, we are using a similar methodology for the other services in terms of using the pre-COVID experience in fiscal 22 in order to not overstate any potential reduction in fiscal 22 relative to fiscal 21 once utilization starts to increase. So you'll see the rebound that we're assuming for physician services and rehab and targeted case management, both increasing relative to fiscal 21 to get back to a pre-COVID utilization pattern. Any questions on other services?
Yep, I got one from Linda here.
I just wanted to check, I know when we go through the questions, the NICU adjustment, that's state only, is that in other medical services, or is it in hospital line?
That's it's in the managed care line. That's further confusing.
The managed care line, okay.
So I see that we've gotten to the end, and before we get into the questions, I have a request that we take a very brief break, say 5 minutes or so, for anyone who needs to take a break, and then we'll just pause and get started in about 5 minutes or so. Appreciate your patience. Ready to restart whenever everybody else is. Looks like we're back. And as everybody makes their way back, I think we will be on to the questions section. Unless there's something else, I think it's probably best to just kind of hit the highlights of the questions. There are extensive answers provided. People have had time to look at it, and in many cases we've gone over them. So if we could kind of hit the ones that we haven't gone over maybe, and then if participants still have questions. Does that make sense? Okay. I'm not sure if, Grant, if this is your area or somebody else is taking this one.
I think Katie was going to take this.
Sorry, I just missed the intro.
So what I would ask is that if you can just hit the highlights. There's so much information here that we've all had time to look at and you've gone over quite a bit of it already. So if we could focus on the things we haven't discussed and then let people ask about the things that maybe they still have burning questions on. That way we can go through this as efficiently as possible.
Of course, that sounds like a great
Okay,
plan.
thank you.
On page 2, I guess, an item of state-only payments. On the provider escalation processes, you would be able to see in RIFAN's first nursing home facility cost of care settlements. I think we had discussed these in a testimony now several years ago before we started the recoupment process, that we were also reviewing cost of care calculations. So a 1.2 million state-only payment was made out for a span of several years, and also a $276,000 payment for just facilities that had deceased individuals with no complete application on file, that were raised through that escalation process. So a payment similar to what an interim payment would have been. That answer also talks about some other state-only payments.
Yeah, actually, we are interested in some detail on this.
Sure.
What was supposed to be a one-time problem now appears to be an ongoing issue, and we're kind of curious about that.
For which, sorry?
The NICU claims?
So last time we actually discussed that this particular NICU issue had been an ongoing. I think we settled on a historic settlement with installments or something was the language that we discussed back in November. So this is another. Essentially, we have an agreement to revisit this quarterly, and it has been in place since I want to say 2017 or 2018, maybe prior. I think what you're referencing is a NICU settlement related to FY20 activity that was one time, which is not repeated here.
Okay, I may be remembering that incorrectly then. Does anyone have any questions
follow-up,
on
I'm happy
these?
to circle back.
Linda?
Is there a reason why it's a state-only payment if you're paying NICU outside of the DRG claim? Should it be Medicaid?
So we're having conversations with CMS about whether or not this alternative payment methodology for NICU cases complies with our current state plan language or not. As it's written, our state plan language for hospital payments is quite specific, but actually doesn't mention specifically admit or discharge DRG, so we are trying to push on that further. But there's a whole page of methodology on our DRG methodology, so it's quite a technical review, which we started at the prior caseload based on this conversation, and haven't completed yet. It is incredibly technical. CMS's initial response was we could, of course, change our full payment methodology to be based on discharge DRG for all providers, which isn't necessarily what we had the intention of doing. It seems unlikely, not to get to veer too far from your question, but if we want to treat then NICU, if we have to change our state plan payment methodology just for a particular subset of providers, it also raises questions of whether we need a waiver for this particular subset of services. So to date, we've just assessed that the additional system changes required to change the methodology for NICU specifically might outweigh the benefit, but we are trying to continue to work and see if there's a way forward with the state plan and conversations with CMS.
And this revolved around the conversation prior of moving NICU into the plans, and that if it was moved into the cost moved into the plans, we wouldn't have this situation? If I'm right?
Correct. That's why we were talking about it at the last testimony. The plans have more flexibility than we do. They have to comply with federal regulation, and they have to use our fee-for-service rate as a floor. But they are afforded more flexibility than we do. In fact, for hospital payments, not all of the MCOs currently pay on a DRG. You just have to, we as EOHHS have to confirm that they are paying at least our fee-for-service rate.
And does this particular situation apply to every discharge in NICU, or is it something that is just in certain circumstances?
It is in certain circumstances. We're actually also working in detail now with CNE to review to understand in much more technical and medical perspective, to be honest, which gets a little bit out of our purview. But my understanding is some NICU cases have the same admit DRG as discharge DRG, so it wouldn't be all.
All right, thank you.
Sticking with highlights, I know we've discussed a lot already of the COVID-19 impacts and uncertainty, which takes us through maybe to page 4, where there are some questions related to the Coronavirus Relief Fund, where we had included several attachments outlining the expenditures made for those various programs. I'll pause there in case there's any questions through that point. It's a lot of content.
No, we're good, thank you.
The next section is about the American Rescue Plan, where there are several Medicaid-specific provisions, which are outlined regarding federal funding for vaccines for COVID, as well as vaccine administration, a change to rebates, and I think there was a specific question which follows about the temporary enhanced FMAP for home and community-based services specifically. So it sounds like there's probably interest in discussing that briefly. Just to state, our testimony as stated in the responses doesn't contemplate additional spending at this time, namely because, similar to our other discussion on the American Rescue Plan, we're waiting for additional clarification from CMS, as are many other states. We're participating in a lot of stakeholder conversations with CMS about what, how that additional FMAP will look and what the impact will be for Rhode Island specifically. But if there's follow-up questions, again, happy to field those.
I think we're good.
I think we've covered similarly a lot of the termination activity questions. I know we did not talk about yet, we have several public health emergency federal authorities, the so-called Appendix K authorities per CMS, which we provided a table outlining had we implemented it or not implemented it, and would it continue through June 22 or as long as we are able under the PHE. I think the table is fully responsive to the questions, but I'll pause briefly.
No, you're good.
We had updated the visualizations of unemployment versus enrollment that we had talked about at length at the prior caseload. We have also provided a list of the FY22 budget initiatives, none of which were, the impact of them were included in these estimates of our testimony, as our testimony is based on current law. We also clarified for you what type of federal authority change was needed, as well as what state changes were needed. There's also the detail that we historically update regarding interim payments. Again, not much to update on the payment side of that equation. We haven't paid out any interim payments since July of 2020. There was a group of questions about the waiver authorities.
Can I stop you before you get to that?
Yep.
There's a question on timely approval process and current backlog of applications. Question was how many are past 90 days, and you've been trending under 100 overdue applications every day for the past 12 months. Can you just refresh my memory and others? What is your volume of applications daily or monthly, or like what is the 100 measured against?
That is a good question. I think while I keep going, I can pull up, I have a dashboard, but maybe I actually can't multitask that well.
Okay, we can go back to it if needed.
Yeah, we can circle back. I can definitely get you that information within this conversation.
Okay.
But we'll keep going and circle back to that. Thank you. On the waiver extension of new programs, there was a question about authorities that we have existing from our waiver extension that we planned to implement in either 21 or 22 that had not been contemplated in the prior caseload estimate. There was one, which was the HCBS expedited eligibility. Expedited eligibility is when individuals can be approved for certain services based on the attestation of their financial eligibility criteria. It has been implemented for 20 cases since June 2020. So our methodology for estimating our expenditures includes those additional expenses. There are not currently any plans for additional waiver authorities to be implemented either this in the remaining months of this fiscal year or next. There, again, we're at the Health Systems Transformation Project, or the HSTP questions. I think that the written responses are fully responsive to the questions.
One question, Linda?
We've been doing this, I think, the past few conferences, so as we get closer to the end of this federal funding, what are you guys envisioning this look like with the managed care plan? So when you talk about the population under the HSTP, how many of your current Medicaid enrollees are involved with the AEs and the managed care through this total cost of care payment arrangement? Because you're dealing with behavioral health, which is an issue right now, so it sort of seems like there's a separate program outside of a larger program that eventually needs to be integrated. And we're starting to see, we have the home stabilization, which is now a Medicaid program that came out of the HSTP, and we're also seeing the community health workers proposal in the governor's budget that also came out of this. So at what point, I guess, should we start to see these two together as a Medicaid program? What are you been envisioning for both of these programs?
Yeah, thank you for that question. This is Ben. I can take that. Let me start by saying, well, let me go to the first part of your question, which was, essentially how does HSTP and the accountable entity program and the managed care program interact, and then speak to the second part of your question, which was on individualized ideas or programs coming out of HSTP. On the first part, anyone who's in an accountable entity is part of our managed care system. So and managed care organizations have a number of contractual requirements to that accountable entity program, and to work with those accountable entity providers. That's pretty typical of any state who has an accountable entity or ACO program in Medicaid, is to build it off their managed care arrangements. I think you said we'll get the exact sort of amount of Medicaid individuals covered by the accountable entity program, but it's high. It's north of 2/3. I'm just blanking on the exact number off the top of my head. And as you sort of alluded to, we are looking at continue in the contract and on other mechanisms, the kind of work that managed care organizations should do to continue the accountable entity program, both with HSTP sort of and in the future. A lot of that has to do with balancing different care management and care coordination requirements. Data and analytics support for accountable entities comes up often as well from the accountable entity side as something that they need help with, and that managed care organizations are better able to do. So within Medicaid, the accountable entity teams and the managed care teams work closely on those kinds of developments. To the second part of your question, we want to identify programs that, like community health workers or like home stabilization, that can be replicated across the Medicaid program, regardless of whether a member is a part of an accountable entity or not. And certainly community health workers is part of that. We, as you sort of alluded to, moving forward, as we wind down the HSDP, sort of funding, we'll need to evaluate how much of those programs can or should continue if we see value, the way we do in the community health worker program or home stabilization program, which are quite well research based and understood, or where the state doesn't necessarily take that lead. Importantly, the HSDP was meant as as bridge funding, if you will. There's a significant amount of bridge funding towards providers developing more facility with value-based payments more generally, And we certainly, as a Medicaid program, believe that value-based payments can and should continue into the future, both within how we structure our Medicaid finance and how we structure our managed care contracts and how we structure the accountable entity program. So there'll always be some, and should be some ability in those value-based payment programs for accountable entities or providers to structure different services as they see fit, particularly as they take on risk or as they are in a value-based payment arrangement. And I think, implicit to your point is it's incumbent upon us to continue identifying those for the conferees. The last thing, just as you mentioned, sort of behavioral health, towards the tail end of your question, we're certainly working closely with managed care entities and accountable entities on understanding how integrated behavioral health will continue to work in this model. And certainly many, actually all of the accountable entities are developing really strong behavioral health components to help achieve that vision as the state considers its investments in this area. We're quite keen to work those as best we can through these existing provider arrangements, given the significant impact that physical health has on behavioral health, and of course vice versa. So long answer to maybe a shorter question, and I'll end because my team has found the exact number of individuals within managed care that are in an accountable entity, and it is exactly 67%. So it's about 2/3.
Thank you.
Before we continue on, we also have found the LTSS application question pre-public health emergency, approximately 400 a month, and I think March, April, about 350 per month.
Sorry, March, April of this year or last year?
This year, sorry, apologies, yep.
So it's back to 350 per month. And the overdue applications are, do you know what it was in between a year ago and now? It sort of seems like those overdue applications would deal with the year I don't have the baseline for. You know what I'm saying?
I don't have that. We can get that to you though quickly.
Yep.
I know that's similarly in Word, so I'll add that to our follow-ups.
Thanks.
In terms of next questions, I think we're getting into another section where a deal of it was covered in the testimony. Particularly, there are questions on nursing home patient share, as well as the assumptions used for the various market baskets in November versus the assumptions used in May. Again, I know that's a lot of content, so if there's any questions.
I'm not seeing any. You can keep going
Great.
until we stop you.
Sure. So going into the managed care lines, again, I think most of this is handled in the testimony. Pharmacy, other medical services, and expansion, again. And I think the last section is on behavioral health, which, again, if there's follow-up questions to what was provided in writing, happy to field those. But I think the questions were about our what amount in our estimates was provided for very specific services, and Desiree walked you through our overall estimating methodology, which was not at that granular of a level. But we have provided the actual spend observed on a monthly basis, similar to what was requested while we were delivering the testimony. So I guess if there's follow-up questions, we can also field those.
We got one question here.
Katie, I know in the other medical services section, there's a line that says BH/DDH Medicaid for about $25 million. And sometimes people will look at it and say that's what the state spends on behavioral health. And obviously we asked a question of on page, your answer on page 19, sort of get to how much in the Medicaid program is spent on these services. Is there a way to get to that number across what the managed care plan spend? So if that question were asked of the Medicaid program, how much is spent on behavioral health? Is that possible to get that answer in the aggregate?
On the managed care side, you get a very high level estimate. There's a component of the rates for behavioral health services that you could use as a proxy. Because of incomplete encounter data, it wouldn't be as granular as the tables that Grant provided in the Q&A, but you could use that across fee-for-service, and I think it is captured in the expenditure report that we'll be releasing for 2019 in very shortly. And so it's not going to be as I said, as granular as the tables provided in the Q&A, but it'll give you a high level value.
Sorry,
As
I'm having
outlined in
trouble
the
hearing
response
you.
that we provided, we can certainly provide an estimate. I think to be any means of precise or to use it with the correct, to apply it correctly would be important. If it's to give a sense of what we spend is more than what is in that one particular component of the budget, we can certainly point you to some places to satisfy that question. But as outlined in the written response, the question, just how much does Medicaid spend on behavioral health, is quite a complicated one of, do you count it by all the spending we do on a person with a given diagnosis, or only on certain services or in certain settings? But we can point you to some resources or similar estimates for sure.
Yeah, if there's anything that you can, I think what Linda's referring to is just the desire to kind of express an aggregate, probably even minimum spending that occurs now, should people mistake smaller numbers for how much the state has invested in this expense or how much it represents as a proportion of all spending. I think that's really not to necessarily do much more than use it as like a illustrative purposes. I think you can keep going.
I think that takes us to the end of the questions, unless again there's particular questions about, there was a handful of particular services without as questions in that section. But
Joe, do you have any questions?
No questions.
Okay, no questions from budget. Senate? I think Senate's good. I think House has asked its questions. Maybe we can just review what we think are the pending items, which I don't believe require another meeting for, unless anyone disagrees with that. I think we can do that remotely and just via email, and we will post the answers you provide. Do you want to go over your list and make sure it's complete?
sure. Yeah, I can build that. I have, I think, 5, if I'm counting correctly. One, a confirmation of what we used in our accruals for interim payments, about what percentage would be not recoverable. There was a request that we discuss our treatment of prior period rebate collection with the auditors, again regarding accruals versus assumption in our ongoing estimates. There was a question about why the size of the decline between November's estimate and this forecast isn't, I think I'm capturing this correctly, isn't equal to 1/3 of the difference between the growth precisely. There was a request for details on the hospital cost report and the potential recoupment specifically regarding the hospital licensing fee, and a monthly breakout of the items in the HCBS table 10-1.
And then just if you can get a little more detail on those applications. I think that captures everything on ours as well. Did I miss anything? Yes. Yep. Oh, well, actually, no, sorry. That last piece we were talking about on the behavioral health as well. Just if there's some aggregate number you could point us to. Joe, did I miss any questions you might have had?
Nope, that's it.
Okay, and Senate, is that everything you know? Okay. All right, well, I want to thank you for your participation and your thorough testimony, and again, apologize for the delay in getting started. If you could just provide that follow-up to us as soon as possible, we will alter the schedule to remove the need for a second meeting.
Thank you.
So thank you, and let us know if there's anything in the meantime. And the next meeting of the Revenue Estimating Conference will be on Friday, April 30th at 9 a.m. That's for the economic overview and some revenue testimony. Thank you very much.
Thank you.